Good morning to all of you. We welcome you all for this week presentation. It's going to be from the Department of Nephrology. We have two presentations. The first presentation is going to be from Dr. Cherian sir, from painful wrist to failing kidneys, an unexpected turn. I'm sure he has given a clue in the first slide itself. I don't know whether PGs have picked up that. Over to you, sir.
Good morning, everyone. I'm Dr. Kamini, Junior Consultant Nephrologist, and Dr. Shalain, sir. The topic for today's presentation is from a painful wrist to failing kidneys, an unexpected turn. Actually, we don't want to, we have withheld the diagnosis in the first slide because we want all of you to have a good experience while going through the case, but I have given few clues in this slide itself. I want one of the PG, you can discuss among yourself, one of the PG to summarize these pictures at the end of this presentation. That PG will get a special chocolate at the presentation, at the end of the presentation. Coming to our case, she's a 52-year female. She's a not known diabetic or hypertensive. She had an alleged history of road traffic accident, a skid and fall from the two-wheeler in the month of April 2025. She had left wrist pain for around 25 days in May 2025. She was treated symptomatically at her native place for a week, but her symptoms persisted. Hence, she visited orthopedic super specialty hospital in Coimbatore. There, she underwent MR and left wrist. There, they said she was having some synovitis along with joint effusion and erosions. They gave the possibility of tuberculosis or non-articular inflammatory arthritis. And also they said some tenosynovitis is present in the extensor compartment. That investigation revealed a negative for RA factor, ASO, anti-CCP, everything. So they did tenosynovectomy of the mid-carpal joints of the left wrist, along with biopsy was done on 17th of May 2025. In that, AFB smear was done, but no AFB viscerally was seen. So she was treated as seronegative RA with methotrexate and steroids, but she was not compliant to these medications. After a month, approximately 45 days, her culture from that biopsy showed growth of mycobacterial tuberculosis complex. But after discussion, she was not initiated on ADT. In October 2025, she had some low-grade intermittent fever for around 20 days. It was not associated with chills and rigors. She had some few episodes of vomiting and nausea. She had a left wrist pain for which she was treated symptomatically with COX-2 inhibitors for around 3 to 4 days. No other symptoms pertaining to CNS, GA or respiratory system. One investigation in which creatinine was said to be normal 0.96 on 11th of October 2025. She came to our hospital on 27th October 2025 with similar complaints, fever, nausea, loss of appetite with wrist pain. She got admitted under Dr. Sendhil sir in General Medicine Department on 27th. On examination, she was febrile, but she was hemodynamically stable with blood pressure was around 120/80, but no tachycardia, nothing. Her hemogram revealed a WBC of 8,500 with neutrophils 66% and lymphocytes 19%. Hemoglobin was 8.4, platelets was 3 lakhs plus, but she had elevated ESR and CRP at presentation. Her renal function test revealed urea of 69, creatinine of 4.4 mg per deciliter with sodium 129 and fairly good electrolytes. LFT revealed normal bilirubin. Her total protein was 7.5 with albumin 3.5 and globulin 4. Slight AG reversal was seen with fairly good enzymes. Urine routine revealed renal protein, but she had plenty of RBCs. WBCs were only 4 to 6 and few bacteria was present. Hence, the urine analysis was repeated. It showed similar results. Again, she had plenty of RBCs. Her chest X-ray was fairly okay. Ultrasound revealed normal size kidneys 12/5 on both right and left side, but she had some increased echoes and fairly maintained CMD. Echocardiogram was done. It revealed normal left ventricular ejection fraction with 60%. So initially, she was managed with IV fluids, IV antibiotics, ceftriaxone, tazobactam, doxycycline, antiemetics, and antipyretics. She was on oral prednisolone. Hence, she was given deflazacort on admission. Multidisciplinary team involving nephrologists, rheumatologists, orthopedician, and pulmonologists were involved, and she was evaluated. During the course of hospital stay, her creatinine was increasing from 4.4 on admission and to 7.7 over the period of 5 to 6 days. At this juncture, we have a patient, 52-year female, with persistent fever spikes, with worsening acidemia of rapidly progressive renal failure, that is the renal failure over days to week, with microscopic hematuria, together termed as RPGN, with anemia, with slight AG reversal was seen, with history of tuberculosis and synovia. We had multiple differential diagnosis at this junction, and we proceeded with urine AFB, urine CB-NAT, which was negative. Mantox test was done, it was also negative. Urine for eosinophils was done to rule out the acute interstitial nephritis because she was given COX-2 inhibitors for around 3 to 4 days, it was also negative. Serum protein electrophoresis was done because of AG reversal, it was also negative. Blood and urine culture done twice, it was sterile. Transesophageal echo was done to rule out the vegetation, hence because she had a picture of PUV, it was also negative. Actually, line probe assay was planned in that synovial sample, but the sample was sent from the hospital to micro labs, but we could not trace the sample, hence it was not done. Then for the worsening acidemia, the RPGN further workup revealed normal serum complements. ANA profile by immunofluorescence showed 1+ positivity with the 1:100 titers. Hence ENA profile was done, it was negative. ANCA profile was done, it was negative. Actually, PR3 and the MPO are the protein which is responsible for the RPGN, it was negative. But weak positivity for elastase was it, but is not significant for the presentation of RPGN. For the PUO, PET-CT was done. It showed only physiological tracer uptake, but no evidence of metabolically active disease in the PET-CT. She continued to have fever spikes, which is shown in the picture. Hence, after discussion with the family and the multidisciplinary team, she was initiated on renal dose modified ATT with ethambutol, pyrazinamide, isoniazid, and levofloxacin. And she was transferred under nephrologist care for initiation of dialysis and further management. On 2nd of November 2025, she was initiated on hemodialysis. After 2 sessions of hemodialysis, she underwent renal biopsy. In the monitor on the right side is the patient's biopsy, on the left side is the normal biopsy with the reference for especially for the PGs. This is the normal glomerulus in hyper view in PA stain, that is periodic acid shift stain. This is the Bowman's capsule, within which there is a capillary tuft. This is the capillaries with GBM on the outer side and the endothelial cell. This is the mesangial cell which anchors the capillaries. And on the outside of the GBM, we have podocyte, that is vessel epithelial cells. The vessel epithelial cells continues as parietal epithelial cells, and this is the afferent and this is the afferent arteriole. This is a normal picture. But our patient, this is our patient's biopsy. This is a medium power view in same stain, PA stain, which is showing 5 glomeruli, 1, 2, 3, 4, 5, out of which 4 glomeruli is showing crescents, diffuse proliferation, with that crescent is comprising the normal capillary tuft. We could not see the normal architecture in these 4 glomeruli. 1 glomeruli is showing partial crescents, and this is the normal capillary tuft. Coming to tubular interstitium and vascular compartment was okay, but mild tubular atrophy is there, and this interstitium is expanded with the lymphoplasmacytic infiltrates. This is the same picture in the HND stain, hematoxin and eosin stain, showing a similar picture. This is that crescents. Immunofluorescence revealed linear ripple-like IgG deposits along with C3c. So they have reported, they actually the biopsy had 21 glomeruli, out of which 11 glomeruli had a cellular crescent, that is more than 50% had cellular crescents and fibrous crescents. IgG and C3 was positive. Hence, they have given the report as anti-GBM mediated crescentic glomerulonephritis. Hence, serum anti-GBM antibody was done and it was found to be surprisingly negative. She had a persistent reduction in the hemoglobin after this episode, so hence 1 unit PRBC transfusion was done. Actually, this is a timeline from the time of initiation of hemodialysis to the discharge. On 2nd of November, we have initiated hemodialysis. After 2 sessions of hemodialysis, we underwent with biopsy. After 2 days, on the 6th of November, we got the report as anti-GBM disease. On the same day, she was initiated on the IV steroids. On the first day, we gave 500 mg, and the second and third day, we gave 1 gram. Together, over the 3 days, we gave 2.5 grams. And she was also initiated on plasma exchange on the same day. Consequently, we did 2 plasma exchange, and after that, alternate days, we did 3 cycles. So totally 5 cycles of plasma exchange was done. After IV steroid, she was given oral prednisone 1 mg per kg. After around 4 to 5 cycles of plasma exchange, her creatinine got stabilized, and she was off dialysis for 3 to 4 days. After 5 sessions of plasma exchange, we gave 1 gram of IV cyclophosphamide before the day of discharge. On 15th of November, she got discharged with these following medications. The Omlocotil 20 mg TDS, that is total of 60 mg was given, 1 mg per kg, and ATT and other renal supplements. At discharge, she didn't have any fever spikes over 4 to 5 days. After discharge, she came to our OP or review on 18th November 2025. On that day, she had a drop in hemoglobin 4.5 with creat of 3.1, but she had hyperkalemia. Hence, she was given 1 session of hemodialysis along with PRBC transfusion. After discharge, she required only 3 cycles of hemodialysis. After that, her creatinine got stabilized, and it was in the decreasing sense. After 3 sessions totally, in hospital we gave 5 sessions. After that, after discharge, we gave 3 sessions totally. 8 sessions of hemodialysis was done. After that, she was off dialysis. Her hemoglobin also picked up after discharge. Her ATT was modified. Actually, once she became normal renal function, her ATT was modified. Her pyrazinamide was modified into 750 mg alternate, and slowly it was tapered and stopped. She had significant hyperuricemia, hence it was stopped. And the dose of 5NH was also increased after she reached the normal creatinine. After in hospital, we gave 1 gram of cyclophosphamide on 14th of November. Then next 2 doses of cyclophosphamide was given in the December and January. Our prednisolone was tapered from 60 mg to 5 mg over the course of 4 to 5 months. Her last visit was on 10th of March 2026. On the day, her creat was 1.1 with hemoglobin of 10.9 with normal urine routine, no proteinuria, no RBCs was seen. At discharge, she's at the last review, she's on Omlocotil 5 mg, ethambutol 400 mg, isoniazid 600 mg, and levofloxacin 500 mg. In a nutshell, she is a 52-year female with no known comorbidities, had some left wrist pain in which the biopsy was showing MTP growth. She presented to us with the persistent fever spikes and RPG in picture. She was initiated on hemodialysis, and the renal biopsy was done, and it showed anti-GBM disease. Hence, she was treated with steroids, plasma exchange, and cyclophosphamates, and ATT for her MTB. And as and when she required, she was given PRBC transfusions. Now she's in normal renal function with creat of 1.1 and hemoglobin of 10.9. This is my first slide, which I have shown. Is there any volunteer in the PGs to explain what I have given? I will help you. Any medicine PGs, anyone? It's okay, no problem. Actually, this is the picture of the left chest with the tenosynovitis. This is the picture of Gilney showing AFB. Actually, our patient didn't have any AFB basically in the smear, but for reference for the EC clue, I have given this actually. In our patient, it was only the culture which grew MTB. This is the type for collagen showing the carboxy and the N-terminal lens. And this is the picture of crescent. This is the picture of immunofluorescence showing IgG. And this is a picture of plasmapheresis. You can see the plasma filter here. I think it's clear. It's plasmapheresis. This is a glue. This is the from the synovial TB. It ended up in the antigen. That is from the infection to the autoimmune paradox. So this is the unexpected turn in this patient. Coming to the discussion, I think I have only 10 minutes. I'll go through the discussion very fast. The patient has had a RPRF, that is the worsening acidemia over the period of days to week. When it is from over hours to days, it usually will cause AK. If it is days to week, you usually cause RPRF. The causes of RPRF are based on the compartments of the kidney, glomerulus, tubular interstitium and the vascular compartment. In the glomerular compartment, we usually call it as RPGN. In this, usually the patient will have worsening acidemia with oliguric picture, but our patient didn't have any oliguria. Oliguric picture with hematuria and proteinuria. The causes of RPGN I'll explain in the next slide. Next comes the tubular interstitial compartment. In this, we have mainly three causes: acute tubular interstitial nephritis, ATN, and myeloma kidney. In acute tubular interstitial nephritis, usually the patient will have oliguric, mostly non-oliguric, but one or two causes will have oliguric renal failure. They don't have significant proteinuria or hematuria or hypertension. The mostly it's caused by infections, especially in our patient, the possibility of TB causing the granulomatous interstitial nephritis was one of the cause, and drugs like NSAID, the COX-2 itself can cause interstitial nephritis. Rifampicin and few antibiotics can cause interstitial nephritis. Acute tubular necrosis mainly seen in patients who are having insignificant infection, hypotension, rhabdomyolysis, and usually they present with oliguric renal failure. In myeloma kidney, the light chains which is filtered in the glomerulus gets combined with the TAM phosphol-14 in the loop of Henle, and it forms the CAS and produces tubular CAS and tubular injury, and usually they will present with oliguric renal failure. In vascular compartment, we have few causes, mainly the TMA, but our patient didn't have any features regarding the vascular compartment. In the RPGN, the classification is mainly based on the biopsy. We have immune complex mediated, anti-GBM and POS immune. Mostly the RPGN will have 60 to 75% will have POS immune, in which we have C-ANCA and P-ANCA vasculitis. Next comes the immune complex mediated RPGN, in which we have IgA nephropathy, lupus nephritis, cryoglobulinemia, IgA. These patients usually have immune deposits in the IF and the EM. Next, our patient is the anti-GMM. In this, we know that circulating autoantibody is present, and they have linear IgG in the IF. And in EF, they usually don't have any deposits. Anti-GMM disease is a small muscle vasculitis in which the circulating antibodies are directed against an antigen that is in the glomerular basement membrane and also in the alveolar basement membrane. There is a similarity for both the GBM and the alveolar basement membrane, which I'll explain in the next slide. It usually presents with RPGN and or alveolar hemorrhage. Almost all the patients who present with alveolar hemorrhage, approximately 90% will have RPGN, but the vice versa is not true. There is the link between this. There is the production of autoantibodies will enter the GBM easily because the GBM is having the fenestrations, endothelial fenestration. Whereas in the lung, the alveolar basement membrane that endothelial cell don't have fenestrations. It doesn't allow the antibodies to enter the GBM. Hence, the RPGN is more common when compared to the alveolar hemorrhage. The Goodpasture syndrome and the Goodpasture disease are the old terms used synonymously, but there is a slight difference in this cause. The syndrome, which we all know, the group of signs and symptoms and clinical features, that is RPGN and alveolar hemorrhage. Many causes are there apart from our anti-GBM. Anti-GBM, the antibodies are directed against any compartments of the GBM. Whereas in Goodpasture disease, there is a particular Goodpasture antigen, that is the type 4 collagens alpha 3 chain. So if the antibody is against this antigen, it is called Goodpasture disease. Our patient comes under antigen disease because we are not sure whether this antibody is against this antigen, and our serum antibody was also negative. Epidemiology, the incidence is quite rare. It accounts for only 5% of the GN and 20% of the crescentic glomerulonephritis. Almost any age group can offer. In the literature, the youngest patient is the 11 months old boy. We usually have bimolar presentation, initially in the 20s to 30s and later in the 60s to 70s. This is the alpha 3, alpha 4, alpha 5 chains of the type 4 collagen. This is the carboxy terminal and this is the N terminal. This at the carboxy terminal, it interlinks to form the trimer and subsequently it forms the hexamer. This is the hexamer, the quaternary structure of the hexamer, which is stabilized in the G-beam and the alveolar membrane. There is a similarity between both the G-beam and the alveolar basement membrane. Usually, this hexamer is cross-linked, and these epitopes are not exposed to outside. If any injury, any environment trigger, infection, smoking, hydrocarbon exposure, these hexamer dissociation occurs. Hence, the cryptic epitopes of alpha 3, alpha 4, alpha 5 is exposed to the body. Our body considers it as an foreign antigen. Hence, the antibodies are produced, and these antibodies gets deposited over the G-beam, and it produces injury. Apart from type 4 collagen, we have few other proteins for which autoantibodies can be formed, that is peroxidosine, laminin, and entactin. These are the environmental triggers, mainly in the pulmonary infections. For example, pulmonary tuberculosis causes damage to the alveolar basement membrane, and it exposes the cryptic epitopes for which antibodies are produced. Other common causes are smoking, hydrocarbon exposure, fibrosis, and lung cancer. In the kidney, the procedures like lithotripsy, urethral obstruction, other glomerulonephritis can injure the G-beam and produce the autoantibodies. Actually, few case reports are there regarding the association of pulmonary tuberculosis along with the glomerulonephritis, but no studies or case reports in the literature regarding the presence of extrapulmonary tuberculosis associated with the anti-GBM. I couldn't find any case report, but I had one. Came across one this phenomenon, epitope memory or the molecular mimicry. Usually when our body gets an infection, any microbe when it enters, it is presented by the antigen presenting cells like dendritic cells to the T cell with the help of MSC type 2. This T cells then causes phagocytosis, or it activates the B cells for further production. But if this anti-GBM, in the anti-GBM disease, if that antigen is having any sequence similarity with the microbial peptide, there is a production of auto antibodies by the T cells, and it induces the GBM, and it causes anti-GBM and the alveolar membrane causing alveolar hemorrhage. So possibly our patient had that antigen had similarity to the TB antigen, hence these antibodies are produced. This is the possible theory. We are not sure whether it is the actual theory. One more thing, our patient's serum anti-GBM antibodies were negative. You said these antibodies are getting deposited in the GBM, but it was not seen in the serum. There are few possible theories. It is because these antibodies are having high affinity, and it got trapped in the kidney and is present in very low titers in the circulation. And these low titers are usually not detectable by the conventional assays, and is also one of the causes our patient, usually the anti-GBM antibodies are IgG. If they are IgA and IgM, it is not calculated in the conventional assays. And apart from our type 4 collagen, other proteins which are shown in the previous slide had anti-laminin, anti-entactin, and anti-peroxidosine antibodies, which are usually not detected in the conventional assays. Few other methods are there upcoming in the research. Coming to the treatment, this is one of the important study in the anti-GBM disease. It is Ramakrishna Hospital study, in which they have studied 71 patients over 25 years, and they have concluded with usually the patients with group pressure syndrome and severe renal failure should be considered for urgent immunosuppression, including plasma exchange, to maximize their chance of renal recovery. This is a conclusion which they have given. Following which the KDIGO also gave similar guidelines for us. For all the patients, when we suspect the anti-GBM disease, we have to start the immunosuppression and the plasma exchange as soon as possible. These are the doses of the treatment which we have given. How long you should give the plasma exchange, and how long should give cyclophosphamide? This is given by the KDIGO guidelines. If we have serum anti-GBM antibodies till the zero, usually the titers will be less than 1.6. If the titers are undetectable, you can stop the plasma exchange. But in our patient, we didn't have any serum anti-GBM antibodies. Hence, we stopped the plasma exchange after her clinical improvement, and after 3 doses of cyclophosphamide, her renal function stabilized. Hence, we stopped the dose of cyclophosphamide also. If the patient is having refractory anti-GBM disease, you can try rituximab also. The recurrences of anti-GBM is quite rare. It's only less than 5%. If it occurs, it's maybe in patients who are having exposure to smoking and hydrocarbon exposure. The treatment is almost similar, same steroids, plasmation, and cyclophosphamide. Thank you.
Thank you, madam. That was a nice presentation, sir.
This case was mainly presented with, because of the multidisciplinary approach only we could handle her nicely and the outcome is good. Usually this will not be the case. First problem for us was the diagnosis of fever. She presented as PUO. So she had a documented, cultured mycobacterium tuberculosis in the tenosynovitis, but still they didn't start ATT. She was treated at Ganga. So we thought they must have some discussion before they decide not to start on ATT. And they gave immunosuppression, methotrexate and prednisolone. If somebody suspected to have tuberculosis, we are not sure. Probably they are very doubtful about diagnosis of tuberculosis. That was the first considered. Second, she came to us, she's one of the VIP patients, I think neighbor to Dr. Kathamut sir. And so many doctors were involved in this case. So that's why they understood the problem also easily. So just 15 days before had a creatinine 0.9, came to us with a creatinine 4.4. With a history of 4 days NSAID. We thought it may be drug induced, so we will wait. We will stop the drug. One thing which gave us a clue was the microscopy hematuria. Obviously clinically no hematuria, but microscopy hematuria, we repeated again, it showed hematuria. And creatinine went up every day. So it is a case of classical RPGN, right, rapidly progressive glomerulonephritis, documented acute renal failure, it's progressively increasing. Usually any RPGN, straight away we put them on pulse steroid. In this case the dilemma was fever and positive tuberculosis, whether to start or not. We had some hesitation. Patient also was well informed and they were also little hesitant about high dose steroid. Already she was on deflazacort for quite some time for her tenosynovitis. Then we had discussion with Dr. Loganathan, Nagendran, Dr. Sendilved's patient basically. Sendilved was there. So finally we thought we will evaluate further and we did including PET and we make sure that there is no other distant focus of any tuberculosis and ATT was started. That time itself I told Loganathan I am going to be planning to use steroids, so better to avoid rifampicin. So he put a regime without rifampicin and then we started on a pulse steroid under the cover of ATT and dialysis also patient took some time, otherwise at least 2-3 days earlier we would have dialyzed her. By the time it reached 7 she agreed for dialysis, dialyzed. After 2 sittings of dialysis adequately controlling the renal parameter, we did a biopsy, we got the result quickly, it came as anti-GB antibody. Initial thinking was about vasculitis because that is a common presentation, but ANCA profile negative, ANA was only 1+, it is almost negative, ANA profile was negative. So anti-GBM we didn't do in the first instance, lung X-ray was normal and biopsy, to our surprise, it was anti-GBM. It was RPGN, crescentic nephritis, that was a clinical diagnosis, but anti-GBM we didn't expect. But that's possible, that is one of the reported cause. Then we have to intensify the immunosuppression. Again, we took the clearance from Dr. Loganathan. We continued ATT, put her on plasmapheresis, IV cyclophosphamide. For renal failure, 1 gram is fairly steep dose, but we thought there is no other choice. We will give a high dose. So patient was also willing to take the responsibility. So then after a few sittings of plasmapheresis and her renal parameters started improving and we had slowly tapered off dialysis, stopped dialysis, continued ATT, continued steroid and gave cyclophosphamide every month for 2 more doses and ATT dose was modified as per the renal parameter improvement and finally the result was good. I never expected her to touch a creatinine of 1.0 because textbooks always say anti-GBM antibody disease who came to you with at the dialysis stage, most of the time they don't recover. Some of the patients they will be on permanent dialysis and everything. Here we had a good result because we were very aggressive in this management. The point what I want to say is, even though she had a documented tuberculosis and other thing, no other choice. Anti-GBM antibody disease, you have to treat aggressively and because of the aggressive treatment only she came out. And we were able to do it because of the backup. We had all team, rheumatology, pulmonology, medicine, and we involved other subspecialty also. So it's an interesting case and finally the result was good. And I asked medicine PGs who were with me during this case, they are hesitant to present the case. So the next PG also I asked, he also hesitant. Finally, Kamini took over, she was not in the field when this patient was initially managed, but she did a good job. Thank you.
Thank you, sir. So we'll have a few questions. Any questions from the floor? So, sir, this is a GBM disease, linear disease. More than 50% of the glomeruli are crescents, severe renal failure, negative lung. Would you expected the anti-GBM antibody to be positive given the severity? One, if not, because of the previous steroids you were suffering on. Can it be another non-anti-GBM IgG4 RPGM?
Biopsy is very clear. Immunofluorescence state showed a ribbon-like pattern. That doesn't happen in any other disease. Only when the antibodies are deposited on the basement membrane, you get that pattern. Biopsy is very clear. So, because
No, biopsy is not really, it is anti-GBM. Just thinking, can it be other DDs for linear IgG4 deposition in the IF, in the glomerular basement membrane other than anti-GBM?
we can have it in membranous and other classes. Some disease you can have. But this presentation is RPGM presentation. Result is that. Even sometimes they said even cadaver kidney, when you do a routine biopsy, you may find a renal deposit. There are so many causes for renal deposit. The common thing is anti-GBM.
Kidneys might have acted as a sink. You know, kidneys might have acted as a sink, absorbing all the antibodies. These are 100% presence, right? So that happens classically.
No, I don't have quantity totally. I'm just thinking what would have other things. Medicine, no? So would you advocate another 3 doses of cyclophosphamide?
Generally, recommendation is only 3. Usually, if it is vasculitis or SLE, there are also other causes of RPGM. The treatment is prolonged. Even immunosuppression, we go for immunosuppression. But for anti-GBM antibody disease, it is only 3 doses. And if you have antibody titer, you are monitoring. If titer has not completely resolved, probably you can try few more doses. But generally, 2 to 3 doses is enough.
But what we used to do in the person when there is pulmonary hemorrhage and anti-GBM antibody is positive, we give cyclophosphamide 6 months because to suppress the the auto-antibodies. And also plasma exchange is variable from 2 to 4 weeks depending on the renal function as well as the disease severity.
Sometimes plasma exchange you can have to do every day for 10 days, 14 days. When antibody was very high and patient is clinically very sick, you have to be even more aggressive. Even daily plasmapheresis for 10 days also is reported.
First slide. That is not for you.
So very boring with the same thought, sir. Some simple neurology quiz for the first slide. Our PG is going to explain. So get up. Sir? I am moderating. But I will get a chocolate. That she says that special chocolate, I think, that I want. Okay. Get up, boy. Sliding.
You have not asked question.
What is the DD for? Neurological point of view, what is it?
Wrist drop,
There is risk of
renal failure, and spirochetes.
it is not AFD, it is spirochetes.
Okay.
Leptospirosis.
Leptospirosis, I don't think.
Excellent DD. It is a wrist drop due to neuropathy. And its arthritis, it is because of leptospirosis, and the spirochetes, it is involves the kidney also. So you are not involved neurologist at this case, sir. That's why we made a differential diagnosis at this point of view. You missed us.
Crescent will not happen. Crescent will not happen.
That is not bother, sir. Result don't bother. Only we want differential diagnosis.
Picture is a manufactured picture just to see that is actually this patient did not have a wrist drop. One.
Yes, sir. We think in terms of wrist drop.
Leptospirosis to have neuropathy is not a focal. It's a diffuse.
Diffuse. That's skin lesion. Usually neuropathy.
Extremely odd.
Yeah, we have seen more cases. Leptospirosis, neuropathy in the common peroneal nerve, and the wrist drop and the radial nerve. We have seen cases, but usually it preceded with the skin lesions. So, thank you for the break.
Chocolate.
Yes, madam.
Morning all. Curiosity always kills the cat, but sometimes curiosity pays a bit to get off an attention. I was actually thinking what topic I should be giving to give it as a simple clinical committee club meeting would have been no-brainer. To do something like an ailing joint and failing kidney, what Dr. Chelian did is something super cool. That's my brain is not going to go there. I was actually lounging where I was listening to some music and was listening to this song, and suddenly this prelude of Ilayaraja's album came, How to Name It. It starts with a good prelude and then moves on to a beautiful violin. Violin is where most of the emotions are, concentrated. So I thought let's just make it a bit curious and interesting and how to name it. I just do not know how to name it. Let's just see how it goes, okay? So, see, this is, I wish postgraduates do open your smartphones in some time. We'll have some online polling and it's open for all. Right, so what you will or what you shall do has always been dictated to us. It has been dictated ever since the religion is being showered upon us. There are three Abrahamic religions that we know of: Islamism, Christianity and Judaism, and they have one God and all of their are messengers, Moses, Ishmael and whomever you consider them. Apparently, Moses led a group of people from Egypt to the top of Mount Sinai, which is also in Egypt. And then while all of them were resting at the bottom, he climbed the mountain and where he, spoke with God. And when he came down with two stones or cloths or Torah, which we call them, which had an inscription that what you should be doing. That is what thou shalt. And this is common in all the three religions that I mentioned. This tells you what you should do, like what, the famous dialogue in one of the Tamil movie. You wake up in the morning, you should do two things. Pray to God, that is good for you. Take a shower, that is good for others, okay? Remember, Vijay, okay? Right. So, there are also things which we should not be doing, which was given to us by Dante Alighieri. There are 9 circles which is shaped like a funnel. The smallest of the crime finds its place at the top, and as the crime severity increases, it percolates down to the bottom, and you meet Satan there. It's a very good meeting, that will be very great. Now, many a times, whether to do or what to do is the question that we have. We are caught between hell and high water, particularly when we physicians, we decide to, prescribe something or not something, whether we take some action, we do something or not to do. We are caught between science and, what is needed there. So, to do or not to do, that's what Shakespeare says in Romeo and Juliet. Now, we say take though, we just give a Latin, we write it and give it to the patient and you do, you take or not to take, that's your choice. We sort of escape the moral high ground and we put it upon the patients themselves. Now, from being, first do no harm, we have moved on to a situation where we can do anything and justify, provided there is some scientific evidence to it. Now, we know how scientific evidence are generated. There is always a publication bias, positive and negative. So, you go to the internet, you will always find some justice for whatever you do. The ultimate, the results is how the patient gets good at the end of the treatment. Now, we all have some pressure to do something. When the patient walks into our OP or into the emergency, we are forced to do something, do some investigation, write something, say something, and come to a conclusion. We cannot send them just like that. We cannot send them with an empty prescription. That's actually blasphemy. We are not supposed to do it. That's a sort of pressure that we have. And we always justify it with the scientific evidence. If you have a slides and you keep working on it, it will cry the result that you want at the end of your session. It is pretty much like driving on the wrong side of the road. We behave as if nobody sees us, we are invisible, but when someone confronts us, then we all have our own excuses. I'm blinking, there's a blinker on, there's a headlight on, why don't you see, why don't you move out, that's a big road. That's a different story, we have our own justifications. Now, that's enough of it. Now I think I have to go into the presentation, it's a long time, okay? So, you can open your smartphones and type this URL. Please look at the capital letters or scan the QR code. This will not take you to the net banking, so please don't worry. I would still be driving a red Polo tomorrow. But if you see me driving a Mustang, then that's not my fault. I'm very sorry. You please ask RBI. The Ombudsman will be responsible for it. Right? Shall we? Can I move? Right. So, see, this is about some case scenarios and what will be commonly done, whether it should be done or not. It's as simple as that. It's supposed to be some information to the postgraduates and us ourselves when we do something, whether it is the right thing or it could have been avoided in certain scenario. It's as simple as that. Now, this patient comes to the emergency, middle-aged gentleman who is a diabetic, non-compliant, high sugars, low BP. We do an ABG, it shows acidosis. So we do some calculation, we come to a conclusion it is metabolic acidosis. We do an anion gap, it shows high anion gap metabolic acidosis. Obvious, right? So we have come to a conclusion that there is acidosis. This patient has a hypotension and he is 2 porous. So the first, the inclination is to give soda bicarb. Now, as expected, some soda bicarb was given, 50 cc as an IV bolus. Now, here are the 4 responses that I have. I want you to choose any one of them. The smartphone will show the screen. You have to enter your credentials and then enter. And yeah, just a second. Right? Is it visible now? Does your screen show the responses? Right, let's see. So there is a response that I'll manage the sugars. Anything else? 100. I said 50 cc soda bicarb was given as a bolus. How many of you would agree that the bolus is good enough? How many of you would say that I would give it as a half normal saline infusion, or I'll manage sugar? And how many of you would say all of the above? So the percentage is varying here. As more and more people vote, we are seeing swing of votes. All right. Right. Looks like new political party is going to decide the outcome, right? There are lots of swing voters here. Right. So, right, we have a conclusion that more than 3/4 would choose to control the sugar. Right. Let's get into the rationale. There is something called as paradoxical intracellular acidosis. We always tend to give some soda bicarb whenever there is acidosis, and particularly when there is metabolic acidosis. But what happens is the soda bicarb dissociates into sodium and bicarb. Bicarb does not easily enter the cell membrane. So that combines with water to form H2CO3, which is split by carbonic anhydrase into H2O and CO2. This carbon dioxide can easily cross the cell membrane, which again inside the cell combines with water to form H2CO3, carbonic acid. And now that kind of lowers the intracellular pH. So what we use to treat acidosis paradoxically worsens the acidosis inside the cell. So that can impair the energy production, reduce the myocardial contractility, and that is shown to have very poor outcome. So it wouldn't be surprising if you get a response over phone saying that he came with acidosis, I gave soda bicarb, but still BP is low. Maybe his BP is still low because soda bicarb is causing intracellular acidosis. So in this scenario, the recommendation is to give soda bicarb if the pH is at the extreme, whether it is around 7, 6.9, that is the case. Now, whether you give it as a bolus or an infusion, if you want to give it as an infusion, the best vehicle is 5% dextrose. Soda bicarb is hypertonic, so you would want to give it as along with a hypotonic solution. You can also mix it with half normal saline. NS is not the best fluid of all. Ideally, you avoid mixing soda bicarb with the Ringer's lactate or magnesium containing solutions. Now, when you find someone with diabetic ketoacidosis, the best fluid of choice there is RL or plasma light. NS is not the first fluid of choice unless there is severe dehydration pressures, but even in that case, RL and plasma light do a good job. Insulin is the magic bullet. As I said, soda bicarb to be avoided unless the pH is 6.9 or 7. Now the reason why normal saline is not the fluid of choice is it has chlorate, it will again worsen hyperchloremic acidosis. Whereas the lactate in Ringer lactate is a potential bicarb, and the ketones which are actually formed during DKA with the help of insulin will become bicarb. So eventually you give insulin and hydrate with RL or plasmalate, you are going to correct the abnormality. The use of soda bicarb is only when the pH is very low. So the point is you don't treat the individual components in an ABG. So just because there is an abnormality and just because we come across the patient doesn't mean we have to do something there. And yes, most important thing, dialysis is not the solution for all sorts of acidosis, particularly lactic acidosis, is dialysis, CRRT, whatever, it removes the lactic acid, but the primary thing should be to correct what caused the lactic acidosis. It's a supportive therapy here. Okay, so that's about acid base. Now we will move on to electrolytes. It's an elderly gentleman who presents to emergency with irritability. CT and whatever you do for the brain is normal. Cardiac workup is normal. Sugars are fine. His sodium is 116 and potassium is 3.8. Now, you will wait for urine sodium, urine osmolality, serum osmolality. You will presume that this irritability is because of hyponatremia. What would be your response? So, either you start normal saline or you start 3% saline at a rate of 20 ml per hour infusion. All right. Right, so here is the response. Either you start normal saline or you start 3% saline at an infusion, or you give 3% saline over 2 hours. What would be your decision now? Right. So, gross majority gives us the vote that they will start normal saline. Another 50% roughly would like to start 3% saline, but there is a little, between whether to give it as a continuous infusion or as a bolus. Right. So, let's go further on. The answer here would be to give 3% saline, but we'll come to it later. See, this is the second scenario. Presume this is the same patient where you have a similar sodium, but the potassium here is 2.1. What would you be doing now? Let's see what the responses here are. Again, you will start normal saline with KCl added to it. You will start 3% saline at the same infusion and you will add KCl to it. You will start 3% saline and do nothing about potassium. What would be your choice now? Okay. So again, a good majority wants to correct both sodium and potassium at the same time. 1/4 would just stick on to correcting sodium. Right. Now, right. So, this is what it is. The response of giving 3% saline in the first scenario where the potassium was normal is right. But when somebody presents with altered sensorium, where we presume that is because of hyponatremia, it is always advisable to give 3% saline as a bolus. The guidelines tells to give you up to 250 cc as a bolus, which we don't generally do, but we can give 1 to 2 ml per kg per hour, which is a safe level of infusion. Now, coming to the second thing, when there is both sodium and potassium disturbance, this is what the change that happens in the brain when there is hyponatremia. Now, because of hyponatremia, there is an increase in total body water. The brain cells also experience the same phenomena. There is an entry of fluid into the brain cells swells, which leads to irritability and in extreme cases, seizures and coning and death. As an adaptive response, brain cell has to prevent entry of water by pushing out the osmoles, which it does by losing sodium, potassium chloride, and over a period of time it loses organic osmoles. Now, the brain stays in a low osmol state for some time. When you correct, if you correct abruptly, when there is a sudden increase, the extracellular osmolality increases, so there is further drawing of water from inside the brain cell, which is the reason for osmotic demyelination syndrome. Now, the trick here is the brain does not recognize whether it is a sodium or potassium. It just recognizes it as an osmol. So when you correct both sodium and potassium, if there is an increase in total osmolar load to the brain, it is still going to cause osmotic demyelination. That is the reason one of the risk factor for osmotic demyelination is severe hyponatremia along with hypovolemia. The point here is immaterial of the level of sodium. Please do not correct sodium if there is no adverse effect associated with hypokalemia, for instance cardiac. But if there is, so then you have to act accordingly. Now, in a similar scenario, when someone has a sodium of 128 and on telmisartan and chlorthalidone, now what would you be doing? I don't know, right? So it's not moving on. Where do I get those slides? Okay. Again, this gentleman has irritability. His sodium is not 116 now, it is 126. Right. So I'll start normal saline or I'll start 3% saline. I'll stop telmisartan chlorthalidone and monitor and take it accordingly. What would be my response now? Right. So I think we have got the point here. There is an inciting agent that is causing hyponatremia. So the best solution is to stop the inciting agent, which is chlorthalidone, and then get on with it, right? Again, here is another scenario which we commonly come across. Here the scenario is same, but the sodium is 400 and its sugar is 430. What would we doing now? Right. Is it going to be same? Start saline or correct? Right? No, that's there is no counter argument here. It's bang on bucks, you know. Right. So here it is simple. We have to correct sodium because there is something called as corrected sodium, where the sodium is falsely low when the sugars are high. So we have to, bottom line is the correction of the sodium has to happen according to the clinical scenario. You cannot apply the same rule to everybody. You have to assess the entire scenario, the other existing electrolyte abnormality before you go ahead with it, because the consequences, though rare, are going to be devastating. Translocational hyponatremia is when the sugars and urea is more. So there is water that is sucked in from inside the cell into the intravascular space. The sodium is falsely low. True sodium will have a serum osmolality of less than 280. As an adaptation, kidneys will eliminate free water when the urine osmolality drops down to less than 150. That is when an adapting kidney will do. Otherwise, it will not. I think I have to rush up here. So, Baptans as a treatment for acute hyponatremia is still debatable. There are arguments to advocate not to use them in acute hyponatremia because it is going to result in an erratic correction. There is a potential hepatotoxicity also. But it can be used in chronic asymptomatic hyponatremia in hypervolemic cases, but we should always be watching for hepatotoxicity, right? Okay. Now, the last few slides are going to be about diabetic kidney disease. Here is a 46-year-old gentleman with 1.6 creatinine who has some amount of protein. Albumin creatinine ratio is elevated. He is on ditar, spironolactone and telmisartan. Now we have to protect the nephrons, right? So we have to do something about it. I'm sorry, I think it is taking a bit of a time here. Maybe it is hanging. Right. So we may not be able to choose hereafter. So either will you give spironolactone along with telmisartan, or will you just monitor the potassium creatinine and continue both, which is more or less the same, but there is a difference between repeating everything and educating the patient and then repeating everything. Will you stop spironolactone, continue torsemide and telmisartan, or add an SGLT inhibitor? May be visible in your smartphones, but I'm not able to change here. It's sort of stuck. would you be continuing spironolactone and telmisartan, or you would educate, stop, or add an SGLT inhibitor? What would be the action here? Right. It's missing. All right. Okay. So I think I'll have to rush through the slides here. Otherwise, it's going to be one. So when you want to protect the nephron, other than sugar control, you have RAS blockers, SGLT inhibitors, and selective aldosterone antagonists and GLP analogs. But you cannot use everything in every scenario. Using both AC and ARB is a big no-no. If you are using spironolactone, watch potassium very carefully. If you are using pindrinone, which is Carandian Lybalsa, which is new, which has relatively less potential for inducing hyperkalemia, you are allowed to use. Again, with SGLT inhibitors, you have to be careful about urinary tract infection. If you are going to combine an ACE, ARB and a spironolactone, and then along with you are going to add an SGLT inhibitor, hoping that you are going to do a full nephron protection, you are actually smothering them. That's not the right thing, because many of these patients will also be on ARNIs, which will contain ARB. You choose the profile of the patient. If the patient is educated and motivated, you can add agents after agents and maximize them. But if the patient is not that compliant, you be a little choosy, you take a step back, use one agent, maximize, and go on to the other thing. Now, the same scenario will not apply to somebody with in an elderly. In an elderly with, in this scenario where he's 76 years with 1.6 creatinine, you may want to be little more easy. You may want to be little more, conservative in using the nephroprotective agents, because they will have stiff arterioles because of atherosclerosis. The moment BP drops, they will end up in acute tubular necrosis. So adding multiple agents may not be of really good benefit. That's what is shown here. Whenever there is a dehydration, the lot of changes happens in the afferent and deferent arteriole to maintain the glomerular filtration. Now, in that scenario, when you use an ACE, ARB, they will inhibit efferent arteriolar constriction. So there will not be filtration. Whenever there is an SGLT inhibitor is in use, it will act through the macular denser mechanism, and it will act on the afferent arteriole, will prevent the afferent arteriolar dilatation, so there will not be filtration. Both the scenario, there will be further nephro injury. So we have to be really choosy according to the profile of the patient. Now, this is something which is very serious, using any sort of diuretic that is possible in the planet other than the proximal tubule diuretics. Now, this is literally like wringing your nephrons and squeezing the maximum out of them. Without proton pump inhibitors, I will not be able to conclude this. Now, they are known to cause acute and progression of chronic hypokalemia, hypomagnesemia, unexplained renal stones, and metabolic acidosis. This was also supposed to be a survey, but unfortunately, it is sort of hanging up. So this is a self-reflection, whether this was worth it or not, or please don't come back to us with this sort of presentation in the future. I don't know. Now, this has no meaning now. Now, this is supposed to be what we can do and what we should do. We can do a lot, but do we really have to do to that particular patient is what matters, and taking the right judgment at right time is going to save a lot of, bad blood and lot of complications in the future. Maybe I'll be able to show this final slide if you can see this in your presentation. How good was this? There was some hanging in between, but that is all technical glitch, trust me. God save us all. I know who gave this. All right. I think your God will save you now because I'm completing mine. Okay? Put your money where your mouth is. That's all right. Good. Let us end this. Thank you.
Thank you, Madhushankar. So my question to you is, what is the name
No, I don't have a name. We don't have to have a name.
Okay, so very good, interesting presentation, covering day-to-day practice problems. So there are some pages there. So what is your final crux message?
The crux
Because
message.
you touched upon hyponatremia, sodium, potassium disorders, volume disorders, pH disorders, and the diuretics of various mechanisms of action, along with the newer HGL inhibitors. So one message, so that it reaches them.
To summarize,
Yes.
there are lots that we can do, but we have to choose what we are going to do, on whom and what scenario. Just because we have a lot of avenues doesn't mean we can employ everything. At times masterly inactivity is as important as going in all out to save, because at 70s and 80s going on with RAS blockers and spironolactone does more harm than good in such subset. That's ultimately the bottom line of this.
Questions?
I'll give a title for your response.
Please.
Living on the edge.
Living on the edge. Cliffhanger, you mean?
So there are no more questions. We thank both the presenters today for their excellent presentation, and thank you all. We'll meet in the next